In the second part of the talk, and this is where we are going to spend most of the time, we're going to discuss neoplastic lesions that can occur in the Sellar, parasellar region, and pituitary area. This is our first case. This is a sagittal T1 weighted image without contrast, where we see a relatively well-circumscribed lesion involving the pituitary gland, the sella, and the parasellar region. We see a small nodularity along its inferior aspect. On the post-contrast images, we see that there is enhancement of the wall of the lesion, and there's also enhancement of the nodule that is located posteriorly and inferiorly. So this is not a simple cyst. This is not a Rathke's cleft cyst for sure. And this is very suspicious for a craniopharyngioma in a child. So craniopharyngiomas also occur from Rathke's pouch, and even though most of them arise from the region of the infundibulum, they can occur anywhere from along that trajectory from the primitive oral cavity to the diencephalon, as we saw on our talk about embryology. And even some craniopharyngiomas can occur exclusively in the sphenoid sinus, but again, for the most part, they will be found around the infundibular region. They present at two separate peaks, the first one in children and young teens, and the second one in older adults. They have a relatively equitative distribution within men and women, and they are histologically benign lesions, but they're associated with high morbidity and a high percentage of recurrence. This is a sagittal T2 weighted image in a separate patient, where we can see this complex, partially cystic lesion in the Sellar region and suprasellar region. There are areas that look dark on T2 weighted images relative to calcification. And we can see that this is an obstructive lesion because we can see dilatation of the lateral ventricles and some surrounding edema related to transependymal flow. So this is the classic appearance of a adamantinomatous craniopharyngioma, which is the histological type that is most commonly seen in children. Axial T1 weighted image without contrast in the same patient. We can see some of the cystic components in the suprasellar region. There's some enhancement of the cystic components centrally and peripherally, and we can see some of that complexity of the mass on the sagittal T1 weighted images with contrast. Axial CT shows us some of the calcifications and the soft tissue elements of the lesion, and the calcifications are better seen on these bone algorithm images. We can see calcifications as areas of signal drop on this GRE sequence, and we can also see some of the cystic changes within the lesion, and we get a good sense of the morphology of the lesion on this sagittal CT reconstruction. So most of the adamantinomatous craniopharyngiomas are going to have cystic changes and calcifications, and again, these are seen in children. Separate case, different patient. We have a cystic lesion in the suprasellar region with peripheral calcifications. On the sagittal T1 weighted image without contrast, we see that the cystic component of the lesion is bright due to proteinaceous contents or hemorrhage, and we see some irregularities along its walls with some small nodules. Axial pre-contrast T1 weighted image shows the lesion with some nodules along the periphery. The nodule anteriorly shows some enhancement on the post-contrast images. This is another adamantinomatous craniopharyngioma, and we can see that the patient is a child because the sphenoclival synchondrosis is still open. As opposed to papillary craniophryngiomas, which are seen most commonly in older adults in the second peak, where lesions tend to be more commonly solid and you don't see as many cysts, and they are almost never calcified. So papillary craniophryngiomas are seen in older adults, and adamantinomatous craniophryngiomas are seen in children. Germinomas are lesions that are seen in the younger population. There is a predilection for the Asian population particularly. Children are usually in their young teens. When we look at tumors that occur in the pineal region, they are more commonly seen in men, but tumors that occur in the suprasellar region have a similar distribution between men and women. When we look at extragonadal germ cell tumors, about 2/3 of them are germinomas, and then we have other tumors such as teratomas, embryonal carcinomas, yolk sac tumors, and so on and so forth. Tumors tend to occur in the midline. Most of them are pineal, up to 2/3, but about 1/3 occur in the suprasellar region. Some of them can be parenchymal, and parenchymal tumors are most commonly seen in the Asian population as well and can be associated with unilateral ipsilateral atrophy of the hemisphere. Basal ganglia thalamus is a good location for intracranial parenchymal germinomas, and you can rarely see them in the brain and cerebellum. They tend to be distributed around the third ventricle, and they have a high propensity for ependymal extension and CSF seeding, and therefore these patients need imaging of the entire neural axis. Because these are very cellular masses, on CT they will tend to look dense. Here we have a case of a patient with a suprasellar germinoma, where we have a lesion that is brighter than cortex, brighter than white matter, because of its high cellularity. This is a non-contrast CT, and lesions almost always show enhancement. And the heterogeneity of the enhancement and the overall appearance of the lesion will vary to some extent depending on the histology. If you have a pure germinoma, as opposed to lesions that may have different types of histology that can sometimes be mixed. On the sagittal T1 post-contrast images, we can see avid enhancement, a little bit of heterogeneity, the lesion extending to the hypothalamus, involving the sellar region, suprasellar cistern, and extending anterior to the pons. On the axial T2 weighted images, we see the lesion to be fairly iso-intense to slightly hyperintense compared to the cortex, a little bit of heterogeneity with small cystic changes. And characteristically, on the ADC maps, we see very, very low signal because of prominent restricted diffusion. And this is one of the important characteristics of germinomas, is that not only they're going to look very bright on non-contrast CT because of the density of the cellularity, but also they will show restricted diffusion with low signal on ADC and bright signal on the DWI images. Moving on to chordomas. Chordomas are masses that can be seen in the skull base. They are remnants of the notochord. About half of them occur in the sacrococcygeal region, and about 1/3 can occur in the base of the skull, particularly along the inferior aspect of the clivus. They tend to occur in the midline. The distribution is usually between 30 and 50 years of age, but they have been described in many ages, including children, and they tend to be more common in men. This is a case of a 10-year-old girl who presented with concern of a mass in the nasopharynx, and we can see on this pre-contrast T1 weighted image, this large destructive mass centered at the tip of the clivus, extending to the posterior fossa. On the sagittal T1 post-contrast image, which you can see the erosive change and the destruction of the inferior aspect of the clivus. There is avid enhancement, and on the axial T2 weighted images, we see that the lesion is very, very bright on T2. And this is one of the important characteristics of chordoma, that on the MR images, they will be fairly well circumscribed, and on the T2 weighted images, they're going to be very bright because of the contents of mucin and necrosis with dark intervening septations. Here we can see the same lesion, axial images post-contrast, where we can see central areas of enhancement and more peripheral areas where we can see this enhancement of septations, small septations that sometimes can give the so-called honeycomb appearance. And that so-called honeycomb appearance we can also see on the T2 weighted images that I have already shown. And what we are seeing is basically puddles of mucin surrounding by epithelioid cells. And you see that enhancement and the T2 hypointensity corresponding to the epithelioid cells and those lakes of mucin and necrosis that are going to look very bright. Treatment is usually surgical with radiation therapy. And unfortunately, these are lesions that tend to have a high incidence of local recurrence, but we do not see metastasis, even though they are locally aggressive. The prognosis is better in masses that present early on and tends to be worse in women and also in lesions that are larger at presentation. Here we have a sagittal reconstruction of a CIS image where we can see the destructive lesion extending to the posterior fossa. On the axial CIS image, we can see that there is disruption of the dura, and we can see extrusion of the tumor into the subarachnoid space. And these patients have an increased incidence of meningitis after surgery, and they have also an increased risk for CSF leaks. So this is an important thing to notice in our reports if we are able to see it. And it shows very nicely on CISS images, particularly when we give contrast. Chondrosarcomas, for the other part, even though they may look fairly similar on imaging, they have a different course. They are relatively indolent tumors. They tend to grow much more slowly when they occur in the skull base. The age of presentation is very, very wide. They tend to be off midline as opposed to chordomas, but there is some histological variants that can have different presentations. Chondrosarcomas characteristically occur at the petroclival sutures or petroclival synchondrosis, as we can see here in this normal CT, which is showing the petroclival synchondrosis bilaterally, compared to this case of a patient with a chondrosarcoma on the left side, where we can see this infiltrative erosive lesion that involves the petroclival synchondrosis and extends to surround the internal carotid artery canal. So this is a case of a chondrosarcoma on the left side. Sometimes we may be able to see the classic matrix of rings and arcs, but oftentimes what happens in the skull base is that it may be hard to define whether this is truly a matrix or if we're seeing erosive change from the actual infiltration of the tumor. On this coronal illustration that I have shown before, we can see that the sixth cranial nerve is the one that is most medially located, as I have indicated. And that is one of the reasons why in chondrosarcomas, as well as in chordomas, the sixth cranial nerve is the one that is most commonly involved. And these patients often present with sixth cranial nerve palsies when they have tumors in this location. So same patient, axial pre-contrast stimulon weighted image. We have a mass on the left side at the level of the petroclival junction, a lot of enhancement following contrast infusion. We see that the mass is very, very well circumscribed, very bright on T2 weighted images, lobulated peripherally. Looks a little bit like chordoma, but it's off-center. And on coronal post-contrast images, we can see the mass off to one side with avid enhancement. Here we have axial CISS images with contrast, where we can see the mass on the left side. We can see disruption of the dura again, and we can see tumor extending into the subarachnoid space and compressing on the pons. We can see the right abducens nerve or cranial nerve 6, the one on the left side. We can see how the mass starts compressing or displacing the sixth cranial nerve on the left side. A sagittal reconstruction shows us again the disruption of the dura, the tumor in the subarachnoid space, and the displacement of the abducens nerve cranially, compared to the contralateral side, where we can see the normal sixth cranial nerve entering the cavernous sinus, which shows enhancement. Optic pathway gliomas are tumors that show slow growth. They are usually astrocytomas. They arise from optic neuroglia anywhere along the optic tracts, from the optic nerves to the optic chiasm and optic radiations. Most of them are tumors that are going to occur in children. We can see these tumors sporadically or as part of neurofibromatosis type 1, and they have relatively different presentations. In adults, most of them are high grade, even though the ones that we see in children are usually more indolent tumors. In terms of localization, there's differences. Patients that have neurofibromatosis type 1 tend to have tumors that are anterior to the chiasm, and almost always you're going to see them in either the orbital or canalicular portions of the optic nerve. Tumors that are sporadic tend to be more posterior, involve the chiasm, hypothalamus, and third ventricle, and they tend to do more poorly as compared to those that we see in neurofibromatosis type 1. Here we have a case of a patient with neurofibromatosis type 1, axial T2 image, where we see expansion of the right optic nerve and optic nerve sheath in a patient with a glioma. On the post-contrast image, we see that there is no enhancement. Enhancement is very variable, and it can range from minimal to no enhancement to very avid enhancement. As we can see here in this different patient with neurofibromatosis type 1, we have two coronal T2 weighted images where we see a mass infiltrating the right optic nerve that is bright on T2 and shows avid enhancement. And enhancement is not related to histological grade in optic pathway gliomas, and we can see no enhancement or we can see avid enhancement as in this case. But what is known is that the tumors that occur in neurofibromatosis type 1 tend to enhance not as avidly as those that are sporadic. This is one case of a patient with a sporadic tumor where we see this large mass is more posterior, centered in the suprasellar region. You can see all the displacement and encasement of the vessels, very bright on T2. Sagittal pre-contrast T1 image shows the extent of the tumor, hypothalamus, third ventricle, avid enhancement, which we can see also on the axial post-contrast images, and no restricted diffusion. So sporadic optic pathway gliomas tend to enhance much more avidly. In terms of aggressivity, there's been different studies that have suggested that sporadic tumors do more poorly, and most of the ones that we see in neurofibromatosis type 1 tend to be more stable, and even in some cases, they may regress over time. Moving on to pituitary adenomas, this is a fairly common tumor, and in fact, the most common cause of a sellar mass in patients after the age of 30. Prevalence is about 17%, and most of them have some excess of hormonal production. Most of the times, that's going to be prolactin. Even though most of them are sporadic, a small proportion is associated with oncogenic mutations, particularly those that we see in multiple endocrine neoplasia type 1. They are benign tumors almost always. We have seen carcinomas, but they are excessively rare, and basically there's no way to tell by imaging on this. We see metastases. But even though they are benign histologically, they can be very aggressive and associated with high recurrence, especially if incompletely resected. Microadenomas less than 10 millimeters and macroadenomas greater than 10 millimeters, that's sort of an arbitrary distinction, but we know that the ones that are small, the ones that we call microadenomas, are usually detected because patients present with functional symptoms from excess hormone production, and macroadenomas are the ones that grew enough to cause mass effect, and patients present with symptoms related to that same mass effect. Coronal T1 pre-contrast image, we see a small bulge on the right side of the pituitary gland, difficult to see. On post-contrast, we can see it more clearly on the right side, and we know that pituitary adenomas enhance less avidly than the surrounding pituitary parenchyma, and that is why we try to use dynamic imaging and catch the adenoma enhancing relatively less to the pituitary gland early on during the sequence. Here we have a midline post-contrast T1 image where we see the normal pituitary gland and infundibulum, and off to the right side, we see the round hypoenhancing adenoma anteriorly. Macroadenomas have a similar tissular signal characteristic. However, when they become large, they become more heterogeneous because they outgrow their blood supply, and they start getting necrosis and cystic changes, hemorrhage, as we can see here. Patient with a mass in the suprasellar region. On the coronal post-contrast T1 weighted images, we can see some cystic changes on the left side, and we can see the extent craniocaudally of the tumor that shows avid enhancement. They can be fairly aggressive even though they are histologically benign. This is a case of a different patient with a sagittal T1 weighted image showing us a large mass that is centered in the skull base, extending to the nasal cavity. We see an area that is bright on T1, superiorly and anteriorly, and that is related to hemorrhage within the mass, which can happen when they become larger. And enhancement is heterogeneous. We can see on the axial post-contrast images extension to the left temporal lobe, anteriorly to the left nasal cavity. And on the coronal images, we can see encasement of the internal carotid arteries bilaterally in this large infiltrated tumor that has cavernous sinus invasion bilaterally. So we know that these tumors can be very, very aggressive and infiltrative. Invasion of the cavernous sinus is important to recognize because these patients are going to do more poorly after surgery. It is seen in up to 10% of autopsies, and by far the most reliable imaging characteristics are going to be encasement of the internal carotid artery and what we're going to see in terms of obliteration of the carotid sulcus venous compartment. So Cotier in the year 2000 evaluated the presence of tumor in the different venous compartments of the cavernous sinus, and the one that I would like you to remember is the carotid sulcus venous compartment, which is here indicated by orange. And they also looked for extension of tumor beyond the inner or outer intercarotid lines, as we can see here, and they correlated with surgical findings of cavernous sinus invasion. And what they found is that if the tumor encased greater than 67% of the circumference of the internal carotid artery, the positive predictive value was 100% for cavernous sinus invasion. So that is the most predictive finding. If the carotid sulcus venous compartment was involved by tumor, then the positive predictive value was also very, very high, with 95% of patients having invasion of the cavernous sinus. If the tumor extended beyond the lateral intercarotid line, then the positive predictive value was also high. If the tumor did not encase more than 25% of the internal carotid artery, there was definitely no invasion of the cavernous sinus. Or if the tumor did not extend beyond the inner carotid line. This is a case of a patient with cavernous sinus invasion bilaterally, which we can see here on the coronal post-contrast images as evidenced by encasement of the internal carotid arteries bilaterally. We can see this in a different patient where we have encasement of the carotid arteries bilaterally in this tumor that is also extending to the left temporal lobe. So if we see encasement, we know for sure that there is invasion of the cavernous sinus, and that's something that we need to indicate in our reports. This is a different patient, sagittal T1 weighted images without contrast. We see a lesion anteriorly in the region of the pituitary gland. On the coronal T2 weighted images, the lesion is very difficult to see because it's very dark on T2. But on the post-contrast images, we see that there is relative hypo-enhancement of the tumor. And this is a growth hormone secreting macroadenoma, and we know that these lesions more commonly are dark on T2 weighted images, and we don't really know why, but they are more frequently darker compared to other histologies. This is a growth hormone producing macroadenoma, and you can see in this patient that the calvarium is very thick because of the presence of acromegaly. Thank you, and with this we will finish the second part of the talk.